So with that sort of stage setting, I'd like to turn it to first Amanda to speak about her work, especially around the future of procurement and other activities and the relevance to this theme. And then to Johanna, especially as she talks about policy approaches to non-communicable diseases, and again connects that to this idea of partnerships and transition. So Amanda?
Okay, thanks a lot, Amy, and thanks to the organizers for including us. So at the center, we're working on a project that looks at the future of global health procurement. And many of you have spoken about the context of transition, that there's a changing disease burden that's ongoing, and there's a changing economic transition as well that's happening. More and more people, more countries and more people are getting wealthier, and most people living in extreme poverty will be in India and in fragile states in the future. So taking those transitions as background, let's look at two other transitions, one that we've already discussed, which is around the changing financing for healthcare in low and middle income countries, including the aid transition, and what I would call a kind of completed transition, which is a technology transition that low and middle income countries are facing, but with a very constrained budget. So first, the aid transition. I'll talk about it through the lens of commodities, healthcare commodities. So right now, about half of medicines in low-income countries are procured by donors or external funders. Half. Then about 10% is covered directly by governments. And the rest is out-of-pocket private sector. Now, there's nothing surprising about that data, but when you think about transition through that lens, and if we look at low incomes and then low middle incomes side by side, and this is a snapshot, so it's not a deterministic travel route from low income to low middle income, but what we see is that the aid drop is not compensated by public spending in absolute terms once a country gets to low middle income. And so you have this period of totally overwhelming private spending on commodities. And I mention that because we have to accept some of that. Of course, we would like to see governments, identifying where needs are and demands are and incorporating more and more of those medicines onto those subsidized lists. But since revenues don't grow as quickly as people's demand for care grows, we are going to see still lots of action in out-of-pocket spending. So I guess one question for us is, how will we structure the availability of commodities into the private sector so that it's achieving the most help that it possibly can for the money, while also working on the public side to try and make sure that essential medicines are subsidized, particularly for the poor? If we don't, we're stuck with inequity. I just saw a study that shows that a month's supply of generic medicines for diabetes, hypertension costs about 10 days of wages for an average public sector employee in Ghana. So you can imagine those are terrible kinds of trade-offs to have to make. So how we structure spending matters. And I would also say that the amount that donors are funding now is very significant as a share of total public spending on health. If it were the case that what we spend now should be taken up by our partner countries. So, for example, GPEI will leave Afghanistan in the next years, and the spend that they make currently is about 15% of total expenditure on health in the public sector in Afghanistan. Now, not all of that money has to be sustained into a transition period, but we would expect that some share does. So just to say, this is big money. This is a big ask on finance ministries, and we need to come together to make that ask. In PEPFAR, for PEPFAR Mozambique, for example. Now, PEPFAR doesn't have a transition policy, but it's likely to prioritize some countries and perhaps allocate less resources to others. PEPFAR represents about 35% of total expenditure on health in the public sector. So it's really important for us to understand, what are we funding now? What are we asking partner countries to take on, and make that ask very coherent. The second point I'd like to make is about the availability of medical technologies. So knowledge and products are really universally known now. If I have a health condition in Lesotho, I know about it just at the same time that someone living in Northern Virginia does. But obviously the public budget that's available to finance health care is so vastly different. And that means that if we don't want implicit rationing and inequity, governments will be saying no a lot more of the time in low and middle income countries. And the question is, first, how well are we preparing governments to take resource allocation decisions in this way? And second, if we do want, if we have to accept the situation that there's a lot of out-of-pocket spending, and I don't think there's any problem with pooled private spending at all. We have pooled private spending in the United States that in some ways is effective at providing financial protection and coverage. But out-of-pocket spending we know is inefficient, right? It's a bad way to buy medicines. It's higher price, et cetera. So if we have to accept that a lot of money will still be out-of-pocket, or needs to be provided by the private sector, do we have a vision for how we would create those markets for private insurers, for example, or for private medicine coverage or something like where you could prepay into those schemes and get better prices? Where is that policy and where is that vision? I don't see it much now. So what are we seeing in markets right now that we have to consider in the context of those transitions? So first we see a market where they're already buying lots of medicines for non-communicable disease. So this idea that the transition is coming somewhere later, it's not the case. It's now. Obviously there's huge inequity, but we're buying those NCD medicines quite badly. A recent study that a colleague of mine did in Ghana found that they were purchasing a statin that at a price that was about 20 times what the UK National Health Service obtains. That's a fail. We need to do procurement better. I think that Peter Sands mentioned this. Second, we see markets that are dominated by the purchase of branded generics. That's due to a lot of different reasons. One is barriers to entry for quality assured generic suppliers, just unattractive markets because we're not making an offer that's coherent. Weak procurement practices, fragmented procurement in the public sector too. So, Kenya, it's great, they decentralized. That was a political imperative, but they also decentralized their commodity procurement too. And we see the effects right away. And there's very low market visibility in terms of data. We don't know we collected actually a very interesting data set, and I think it was the first time that we were able to see who's buying what from where in a country. And it's quite valuable information. It's like, I don't know if you're aware of IMS or the IQVIA data set, but we probably need something like that, but in the public interest, servicing public procurers as well. I'm also quite worried about outside of Gavi and the Global Fund, there's some kinds of classes of commodities, like child health commodities, that we're still also buying in a very disorganized way. And I've recently, through the interviews that we're doing with this project, have heard stories about, oh yeah, you're buying the basket of child health commodities today through UNICEF and it's funded by one donor, but the money's running out next year. We think it'll be renewed. We're not sure. Oh, I'm going last minute to Gates to ask for the money to substitute, or I'm going last minute to This is no way to procure essential child health commodities. Can we start to look at that gap in the kinds of things that we're buying? And then, of course, the increasing preference for local manufacturers. Could very well be that there's an economic case for it. We don't necessarily see it in the prices that are being obtained, and of course there are the concerns about quality. So if countries are really going in that direction, what is it that we as the international community could do to improve that situation? So okay, in terms of new directions and what we should be thinking about going forward, two things. One is that if the reality is that the future is domestic procurement of commodities and a lot of domestic manufacturing, then we might need to think about very comprehensive programs of reform and policy dialogue with countries to get the regulatory environment right, to assure better competition among quality assured generic manufacturers, and to build procurement as a real function of the health system. It's not in the building blocks at the WHO right now. There's rarely a chief procurement officer. There's a disconnect between selecting a product, listing it on an essential medicines list, deciding to buy it, and then the actual procurement process, that whole process. And then the instruments that we're using in the developed health systems and in the private sector, they're using auction methods, they're using lots of really interesting contract structures or tendering structures to be able to get the best possible price. We are not seeing that in the global health procurers or at the country level. So there's just a whole set of things we can be doing there. And I just wanted to mention Cameroon has this very interesting procurement agency that helps to structure that private spend too. they buy for the public sector, and then they sell their wholesaling, their procurement function into private pharmacies as well, making sure that a quality assured product goes through private pharmacies as well. So that's a really great set of things I think we can think about for the future. And then the final is around sort of reformulating the vision for the global funds and the procurers in the future, in the post-aid world. What should this look like? We hope that there's still some version of aid, but it probably needs to go to 3 uses. 1, innovative products. If we think something is innovative, on patent, and highly cost-effective, but out of reach in terms of affordability for country health systems, there is definitely a role for these entities to do that kind of pooling or framework agreements with a copayment. Second, on global public goods. There are things that we as a global health community think are vital, that are cost-effective at the global level, let's say polio eradication, but that actually are not cost-effective from a domestic budget decision maker's perspective. That's a perfect place, and Gavi is taking that place in financing IPV, for example, or co-financing IPV. And then finally, the issue of kind of equity and incentives for equity in reaching key populations that Peter Sands mentioned. That's always going to be a really important part of those global funds mandates. So I think we need to start articulating those arguments. We are not just saving lives. You know, we need to structure a post-aid world that makes the market work for more people. Thanks.
Great. Thank you very much, Amanda.